This next segment doesn't have a lot of writing on the board, so I'm just going to sit here and talk to you, just a little more relaxed. Everything I put on the board, I hope you got, because it's all really important. To really understand the complexities of the system, you have to understand why things are happening, why we use specific processes. Clinical pathways, disease management is the way it's going to be, and it does work. It does provide the best results both for the patient and the facility and the healthcare health insurance company and the government. And if it makes the government spend less money, it's less money out of our pockets. So it's kind of like it's all talking about us. We always want to use evidence-based practice. That's what drives the care maps. There is steps of using evidence-based practice, though. I mean, just because you have evidence doesn't mean that the information you're going to use is useful. I need a drink of water. Let me give you a for example. Let's say, remember I told you about the pediatric blood transfusions, and our hospital was able to drive a new policy. We researched pediatric patients who received blood transfusions. That's very relevant. Would it have been as relevant if we used blood transfusions as a whole? Probably not. Blood transfusions of only the elderly? Probably not. So you need to find evidence that's relevant to your question. And then look at the evaluation. You need to critically evaluate the evidence found. Is it logical and valid? Logical and valid. How many, if they did a study, how many people were in the study? Again, if you look for that pediatric transfusion research, if the study was based on 2 patients, is that a real good study? Or is it on 2,000 children? So look for the strength of the research. Look for the age of the research. I mean, seriously, research that was done last year will almost always be better than research done 20 years ago. Right? That doesn't mean information from 20 years ago is useless, but it means you need to look at more recent whenever possible. Look to see if the information you're finding actually fits your clinical experience. For example, the research made in blood transfusions, let's say that, was using a type of filter. I'm going to grab something random. A filter system that our hospital doesn't use. So that might change the level of confidence in that. The last and probably most important aspect is, will the client, the patient, accept the recommendations from the evidence? You know, if the evidence is great, recent, of a large population, directly relevant to you, but it involves excruciating pain for the patients, they may say, I ain't doing this, right? So you have to look at everything. It's not just the evidence, but evaluate the entirety of it. We talked briefly in the beginning about the nursing shortage, how it was much worse about a decade ago. It's better now. It is better now, but it's going to start getting worse. A few years ago, and this is probably 2005, there was a study that showed 55% of nurses at the time intended on retiring between 2011 and 2020. More than half of the nurses were going to be retiring in that 9 years. And we are halfway through it. So in the next few years, there will be a larger demand for skilled nurses. You are in school at the perfect time. What can we do to recruit nurses into the profession? And I'm asking that as part of the lecture, but also, what can we do to get more nurses? What can we do to get more nursing students? Why did you choose to become nurses? And how can we use that to help bring other qualified people in? I don't have an answer. My PowerPoint here suggests using recruiting materials distributed to hospitals, high schools, and nursing schools. Well, if we're putting information in nursing schools, presumably students are already planning on being nurses. I don't know about high schools even. I know that that's the trend. How many of you, when you were in high school, knew that you wanted to be a nurse? I didn't know until I was 30. So I don't know how to do this. Improving work environment would definitely be a start, though, because nurses are underappreciated and overworked. In fact, just yesterday, today is July 17th, just yesterday when I was at home working on grading papers, Katie Couric was on TV, and it was the first half of her show was on nurses. And exactly that, nurses are underappreciated for all the work they do, which is kind of cool. And she had a guy on there, which made me feel really happy. Jason, you got to know that you're going to be outnumbered wherever you work. And so whenever we can get a guy having prominence and recognition, that's really important. So how can hospitals retain nurses? Well, there's a lot of ways of doing it. Some easy, some not. Adequate compensation. Pay us what we're worth. Give us flexibility in our scheduling. It'd be really cool. When I worked at Bellin Hospital in Green Bay, we self-scheduled. Nobody wrote the schedule for us. Blank schedules were posted, and we signed up for the hours we wanted. Now, if you were working at the time the blank schedule went up, you obviously had first crack at shifts. So there is some inequity there, but it still gave us the control over when we work and when we don't work. I liked the schedule, and it works in small units. When you have a small unit of people that really work well together, it's great. For a large unit, it would be a nightmare. How about if we were allowed a little more autonomy? If we had the authority to make decisions? How would you like it as a nurse if you're taking care of a patient and suddenly you have let's say you're taking care of an 85-year-old wonderful lady. She's just incredible. She's there because she broke her hip. And, she's pleasant. She has some pain, but she's cooperating and she's working as hard as she can. And then next day you come in and she's like out of her mind crazy. She's just, she's totally different personality. What's going on? UTI. How would you like it in that situation if you had the authority to order a UTI urinalysis? Instead of having to go to the doctor, say, doctor, here, give the SBAR thing and ask for UA, if you just went and did it. There are hospitals that have things like that. They're called protocols. Nurses have protocols where if they see this, they're allowed to do that. That's cool. When you have some autonomy, that's nice. It speeds everything up. It also makes us feel like we're valued. Make sure there's a good leadership style. Ideally, you want to have a nurse who has experience in that type of nursing being your leader. Not necessarily from your department. That can be challenging sometimes when you have a coworker who was once a coworker and is now your boss. It doesn't always work. In fact, almost never works really well. But if you're working in a hospice unit, it'd be great if your leader was a hospice nurse. Get some work recognition. Let's say, how would you like it if when you graduate, wherever you're working, puts your name in the paper saying, Cammie graduated with an associate's degree. Bozina graduates with an associate's degree. Wouldn't that be nice? Or they post in, Ashley just passed her NCLEX and is now an RN. Angela passed the test to become a critical care registered nurse, a CCRN. Jason is entering school to be a master, get his MSN. Stuff like that costs nothing. But would it make you feel better? Would it make you feel recognized? Probably. Might embarrass you a little bit. That's what's fun. If you can't embarrass a coworker, what the heck? Better working conditions. Here's something that I found was relatively minor, but man, was it nice. When I was working in the ER, we had a coffee maker, and we had to make our coffee. Now, the hospital bought coffee grounds. They bought They bought bad coffee grounds, but they bought coffee grounds and filters and stuff like that. We always brought our own coffee in because we brought the good stuff in. But we had to make the coffee, and inevitably the coffee pot was empty when somebody wanted it. Eventually, we asked and got one of those machines where you just pull the handle and coffee comes out because it comes from a concentrate, and good coffee right there on the spot. You can get coffee, you can get decaf coffee or hot cocoa. And those machines are provided by the distributor, so it costs them nothing. It was great. It was wonderful. A little condition just made us feel better. Magnet hospitals are becoming a major thing. There's on page 317, box 15-2 talks about magnet hospitals. Now, I'm going to give you a disclaimer there. The requirement for this class is that you buy the book, Nursing Today, edition 7. Wonderful. I'm happy with that. Unfortunately, for some reason, the publisher also has published in a 7th edition revised. And everything's off by about 4 or 5 pages. I don't remember which way. This is just a side note. But I'm sorry, if you publish a book and you change information in the book that changes the paging, that's a different edition, isn't it? Whatever. Anyway, approximately page 317, give or take 4 or 5 pages, either way, there's information on magnet hospitals. Magnet hospitals are all about quality nursing care. And there's 14 forces of magnetism. This is why more and more hospitals are expecting bachelor's prepared nurses. Because to be a magnet hospital, you must have a minimum of 50% of your nurses with a bachelor's degree or better. Unfortunately, in Wisconsin, we are a very strong associate degree nursing state. So many hospitals do not have that 50%. So if you have that BSN, it makes you a more viable candidate for an opening. Even if you just are enrolled in a BSN, makes you a better candidate. So graduate and then get enrolled in a BSN, even part-time, will make you more marketable. Healthcare organizations, there are different types of healthcare organizations. 3 types: centralized, decentralized, and product line. Centralized means that everybody has less personal responsibility. The supervisors and managers direct the nursing staff. So your manager's out there all the time telling you pretty much what to do and where to do it. Controlled. Decentralized, nurses have more responsibility, more autonomy, more accountability. So less oversight. However, when things go wrong, you don't have that manager there to backstop you. So centralized, more control, but when something happens, you've got somebody right there that can make decisions. Decentralized, less control, but when something goes wrong, It can go wrong bad. And then product line simply means the type of organization is organized around a single product line. It may be an eye care clinic where everything is around the eyes. Might be a standalone surgery center. It might be visiting nurses association or a hospice. It's one product line. Again, focused, which is good. You get very good at one area, but you lose experience elsewhere. For good quality health care, we need to provide health care that's safe, effective, patient-centered, timely, efficient, and equitable. Now, I want to point out a couple things there. Isn't effective and efficient the same? No. Effective means what you're doing gets the project done. Efficient means what you're doing gets it done quickly or inexpensively or smoothly. You can be effective and not efficient. You want both. You want patient-centered, so everything you do focuses on the patient. Timely means, obviously, when the best possible time. And then equitable. Treat everybody the same. Doesn't matter who you're taking care of, treat them the same. Now, there was the 5 Million Lives campaign was designed to enroll 4,000 hospitals to improve the lives and save 5 million lives over a 24-month period. It raised the profile of the problem because at the time, this is in the 90s, 1996, that it just wasn't, there were problems in the hospitals. And what's interesting about this is one person in the Institute of Medicine decided that we need to fix this. And that one person actually said, before the 5 Million Lives campaign, he started the 100,000 Lives campaign. And he was very, very specific. He said, 100,000 lives in 18 months. We're going to save 100,000 lives in 18 months by doing 6 things. Rapid response teams, evidence-based care for heart attacks, preventing adverse drug effects, preventing central line infections, preventing surgical site infections, and preventing ventilator-associated pneumonia. 6 things. And actually, at the end of the 18 months, it was expected or calculated that actually 123,000 lives were saved. But one person did that. One person, nationally, because he realized that there was a problem and we needed standardized cares. There are new preventions now, preventing pressure ulcers, reducing MRSA, surgical site complications. There's just, it's an ongoing process of always trying to provide the best possible care. So when we go through changes, when we want to save those 100,000 lives or the 5 million lives, when we want to reduce ventilator-associated pneumonia, what do we do? How do we make that change? There is a process. Remember, processes, structures, and outcomes. The process, first we have to know what we're doing. Let's say that the goal is to prevent ventilator-associated pneumonia. So that's what we're trying to accomplish. How will we know that there's an improvement? Well, hopefully we've got some studies that show how many times in the past we've had VAP. So we can say we know that we've improved if there's a reduced number. What changes can we make that will result in an improvement? So we have to evaluate what can actually be done. We come up with a plan. We do it. We study what happens. And then we act on it. We either improve it, we make tweaks, or we keep it the same. It's a process. You have to have every step before you can actually accomplish anything. I'm going to come back to patient care delivery models. I'll be back to writing on the board for this one.